Hello and welcome to the fourth webinar in our series, Person-Centred Care in Practice. My name's Anna Flynn and I work at the Australian Commission on Safety and Quality in Healthcare. Before we start, I'd like to acknowledge the traditional owners of all the different lands on which we're meeting today. For me, that's Gadigal land, and pay my respect to elders past, present and emerging. I would also like to extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander people joining us today. In today's webinar, we'll take a look at health literacy and how it contributes to person-centred care. Health literacy is vital for partnerships to work in healthcare. It's about how people understand information about their health and healthcare options and how they apply that information to their lives, use it to make decisions and act on it. Here at the Commission, we separate health literacy into two components. Firstly, individual health literacy, which includes the skills and capacity of a person to understand and apply information to make effective healthcare decisions. And secondly, the health literacy environment, which applies to the infrastructure, people and policies that make up the health system and impact the way that people access, understand and apply health-related information. Today's presentation will demonstrate an approach that covers both of these aspects. And on our website, we have a range of resources for consumers, clinicians, and health service organisations to support a better understanding of health literacy and some suggestions for improvement. But before I introduce our presentation today, I'd just like to remind you about our Person-Centred Care Resource Hub on our website, where you can find all things person-centred care, including the recordings of the previous webinars. And don't forget to join our network. The next newsletter will be out very soon and it's jam-packed with examples of the work that you are doing in person-centred care. It's been really great to read through so many innovative projects and we're really looking forward to sharing them with you in the coming weeks. And just a bit of housekeeping before I introduce our speakers today. After the presentation, there'll be a live Q&A. So please type your questions in the Q&A function. Also, at the end of the webinar, you'll be sent a short survey. And as always, we'd really appreciate your feedback on today's event. So without further ado, I'd like to introduce the team from Illawarra Shoalhaven Local Health District. Fiorina Mastroianni is Partnering with Consumers Manager in the Clinical Governance Unit. Christy Harrod is a Nurse Educator and Health Literacy Ambassador in Renal Services. And Joe Spicer and Gail Sweeney both work in consumer advocate roles in the Clinical Governance Unit. Over to you, Fiorina.
Hello everyone, and thank you, Anna, for the opportunity to present today. We're speaking to you from the lands of the Dharawal and Yuin Nations, from a beautiful coastal strip in southern New South Wales. We have a population of about 400,000 here in our area. So our presentation today is called Health Literacy and Patient-Centred Care. It is about everyone. And I'm joined today by my colleague, Christy Harrod, and our two consumer representatives, Joe Spicer and Gail Sweeney. Our journey towards becoming a health literate organisation started about 10 years ago. And the reason we embarked on this journey was because we understood very early on that health literacy was concerned with equity and fairness and also about communication. We understood that poor health literacy had significant poor outcomes for people potentially and poor experiences. We understood health literacy, if we wanted to go with a definition, I think everybody's quite familiar with it, but health literacy is about the skills and knowledge that a person needs to effectively understand and use health information and services. And we know that only around 40% of the adult Australian population has these skills. And then there are even more vulnerable groups in the population, such as older, frail people, people from non-English speaking backgrounds and so forth. So we know that this is a significant issue in health and we wanted to do something about it. So we started on this journey, and one of the first things we did was we put together a health literacy framework. At the time, there was no national framework. There There was no framework in New South Wales, but there was a lot of evidence out there for best practice, particularly the US Institute of Medicine's 10 attributes for a health literate organisation. And we took this on board. This formed the framework, or the basis of our framework, and we were guided by the principles of universal precaution, or organisational responsibility and avoidable risk. So with universal precautions, basically what we were saying is that everyone is at risk of not understanding the information they need to make the health decisions that are best for them. And so we decided very early on that we weren't able to or going to look at assessing individual health literacy, but we would take a whole of organisation approach and put in place improvements that would benefit everyone. We had a staged approach. We used systems thinking. Our priorities were to skill the workforce through our Health Literacy Ambassador program, to set up our plain language information system for consumers. And we also wanted to make sure we started on wayfinding. Today, we want to talk to you about our journey, where we've come, and what more we have to do, and give you some practical information about what you can do in your health districts organisations. With consumer engagement, that's always been a really critical part of our health literacy journey. We've got consumers are partnering with us to develop and test our consumer resources, to help us improve the navigation through our facilities and hospitals, for example. We've also, consumers are starting to get involved in leading health literacy projects, and Gail's going to give you more information about one of those projects later on. But we are doing some really, also in 2020, we introduced a framework for how we can engage with consumers in the governance and service planning space. And we've got some consistent or standardised processes for how we recruit, onboard consumers, orientate, support, remunerate, how we train our staff to work effectively with consumers. And we have a number of consumers engaged with us in this work. And this is kind of like in its infancy, really. 2020 is not that long ago, and we've got a lot more work to do in that space, but we are really excited about that. And I'm just going to hand over to Jo to talk about where we're going with all of this at the moment.
Thanks, Fiorina. I was fortunate and excited to be one of the early consumers recruited in 2020, and it's been great working with clinical governance and with Fiorina and the team there to begin the process of onboarding and supporting and creating consumer engagement with ISLD. We have progressed quite a way from the beginnings, and moving forward, we're looking at currently creating a community and consumer engagement working group. This advisory group we're in the process of putting together the terms of reference and creating an organisation that will advocate for the community, for consumers and for carers, consulting with community influencers and representatives who are key to helping us have literacy and engagement throughout the entire area, making sure we connect with all the groups that are there, because obviously there are some groups who are have communication difficulties, and it'll be important to make sure they're represented in all the work we do as well.
I just want to talk to you about the wayfinding program. This was one of the early things, one of the early initiatives in our health literacy journey. In fact, we started our wayfinding around 2012. We saw this as a great starting point to engage staff and consumers in health literacy. We've always made sure to make our health literacy initiatives and work whole of organisation with standardised processes. So there's always been a strong governance approach, and we've resisted the temptation, which has been there quite a lot over the years, to do things just in one area or in one facility. We've always made sure that we've gone whole of organisation. I think we've reaped a lot of benefits from that. So that's kind of one thing that we would really recommend for anyone who might be working in health literacy space or wanting to develop up some initiatives like this or programs, that whole of organisation is definitely the way to go. So we have, this has now become integrated into business planning across the district. And you can see from the table that it's got a lot of information on it, but this is from Integrated Community Services, which shows that we have a 3-year cycle. It talks about the last wayfinding audit, when the next one is due, that it's been scheduled, who's supporting it and where it's happening. And this is the way it happens across our district now. So we've been able to devolve that from clinical governance out to all the facilities and services, which is fantastic results. That's really embedded in the way we do business, and people just accept this is what we do. And it's also accepted across the organisation that consumer engagement is a core component of this. So we work together on the audits using standardised tools for checking and standardised tools for action planning. And you can also see on this page some wonderful feedback from Eileen, one of our who worked with us in the early years and until she moved out of the district. And she was, as you can see, she's vision impaired. And she talks about how the wayfinding work was really powerful for her, and in fact, her most rewarding advocacy work, because she was able to see real differences. You can also see a picture of sliding doors. You might think, oh, that's not that great, but that was a huge achievement for us. Those sliding doors are to the aged care ward at one of our hospitals. And it was through the wayfinding audit that we were able to replace some really heavy manual doors that no one could get through, really, who may have had disability or frail and aged, to these automatic doors. And that was a direct improvement that cost a lot of money, but without the power of the consumer voice, that would have been impossible. And we also could see that Wollongong Hospital Emergency Department, for example, after putting in significant wayfinding improvements and work, there were great improvements there that we saw in the Bureau of Health Information Patient Experience Survey. So that was fantastic to see that. Then in 2013, after we got wayfinding in place, we worked on a couple more programs and systems: the Plain Language Patient and Consumer Information System, the Patient Information Portal, PIP, and the PIP process, which is the process we use to develop, test and store our community information resources, the written resources. So this has been now picked up by a number of other health organisations in New South Wales, which makes us really proud and happy to see that happening. With the PIP process, an author of a document will register the resource and then use standardised templates, writing guides, images, etc. to develop up their resource. They're aiming for a grade of 6 to 8 reading level. And then that resource is tested with the minimum of 5 consumers who would be the end users or people who might support end users of that resource. That information is logged on the feedback tool that you can see on the screen. And that information, as well as feedback from staff, is all used then by the author to refine the document, and that becomes the final resource that gets published on our patient information portal. We did a great study with the University of Sydney in 2019 to test the effectiveness of our PIP process, and from some fantastic results. What you can see there on this screen is how we have monitored over the years the number of resources that we develop, how many consumers are involved in helping us to do this work, and it's growing, and there are spikes there which are in line with accreditation events when they used to be 3 yearly. But with the results chart on the right, what that's saying is that our resources are higher in quality. They're easier to understand and use after they go through the PIP process. And they're even higher in quality again after they've been tested with consumers, and that feedback is incorporated into the final resource. So we were really, really excited to do this study and to see these results. And that has confirmed the Illawarra Shoalhaven Local Health District PIP process as an evidence-based approach and system and process. And we've been able to now see this embedded, similar to wayfinding in our district. So we've changed language in our district. So you will hear staff talk about, have you PIP'd that? Which means, have you followed the process to put this resource for consumers in plain language? Have you tested it? Is it on the right template? Are you using approved images? And has it been published on the portal? And that's what that one phrase means, all of that, and that's changing the culture. So we feel we've really matured, and it's just amazing to see this embedded. It won't be lost now. Our Health Literacy Ambassador program is also a program that we started in 2013, and it is goes hand in hand with the patient information portal. We have 30, when we started in 2013, we had 30 health literacy ambassadors, and now there are 183. That represents around 3% of the total workforce, which might seem like not a lot, but when you look at other champion programs in healthcare, that's not bad at all. We run a 3-hour education program. We offer it quarterly, and we also will train whole services or teams. The role of the health literacy ambassador, and Christy, who's online today, is a health literacy ambassador, so she'll probably say a bit more about her role. Essentially, it's an act to advocate for health literacy and how important it is for safe and quality care and for patient experience. We know from numerous evaluations we've done with our health literacy ambassadors over the years that the main work they do is around creating patient information resources or working with their colleagues to do that, promoting, building awareness of health literacy, helping people to access the patient information portal and all the resources that are there. And these are their main, and also working on plain language policy documents is also something they're involved in. And when we did the survey, we could see that the 73% of our health literacy ambassadors will be working in the plain language consumer information space. So this is, it's important here to emphasise how the role of a health literacy ambassador is anchored to the patient information portal, that it's important to have, like, I don't think we would have the success we have with our HLA program if we didn't have a plain language patient information system at the core that that really defines so much the role of a health literacy ambassador. I think this is a critical learning for us. And you can see from the chart how the numbers have grown over the years and continuing to grow. We are training more and more staff each year. It's again seen as kind of key learning for health workers in our district. Teach back and check back. I might take you straight to the bottom, which is something Jo said. We each have a role to play for effective communication. So I might just hand over to Jo, who might talk to you about the communication work she's done in health, and also Jo, if you wouldn't mind talking about the work we did with training the doctors in obstetrics and gynecology.
Sure, Fiorina, thank you. Teach back. When Fiorina approached me about the concept of teach back, I thought it was just brilliant. My work as an author and a researcher has involved speaking to many and interviewing many patients from the cancer space, from the pregnancy and birth space. And a lot of the difficulties in their experiences boil down to communication and misunderstanding. These two concepts, teach back and check back, are aiming to ensure that the medical personnel, the staff member and the patient are actually communicating together rather than at cross purposes. As you all know, someone can say something and have a certain intention, but the way it's received might be different based on the two different people's experiences and level of health literacy. So Teach Back was a great concept, and Fiorina and I organised a training session with the obstetrics and gynecology department, where we helped them see the importance of when discussing issues with a patient, to teach back and make sure that they really understood. So what that involved is if they're providing some information, to ensure that there was understanding, to ask the person to repeat it back to them to make sure that they actually processed what was being said. When you have to say something back that you've been told, it activates another, I guess, another different spot in your brain, which helps information sink into the understanding level. So I think for the doctors and the nurses who were involved in that workshop, it was really great for them to understand that when they just provide a whole lot of instructions or information on how to deal with medications or what they should do, you know, people as a patient, you don't want to, you know, they're busy, you don't want to be a problem. So a lot of people just nod in agreement and say yes, when they don't really understand or remember what the medical staff member told them. So this little process of checking back with them and saying, so what you need, if the medical staff said you need to do this and this, do you understand? Can you explain to me what I suggested that you try? And then have the patient reply back to them what was said. At least that is a great method to make sure that they have understanding of what was expressed. The check back side is that the patient side of the equation, we have a duty of care for ourselves to ensure that we understand what's happening and we have a certain level of health literacy. So when I speak to people I know who are going through maybe chemo or other medical procedures, I always say to them, don't be afraid to ask questions. Check back with the professional. If you're not sure exactly how to take that medication, feel free to ask questions and say, could you explain that again? Am I understanding this correctly to say that you want me to do this every day at a certain time? So I think the magic happens when both sides work together, because it's about all of us. And when each side does their best to connect and actually understand each other, I think that's when effective communication and effective healthcare can happen. Back to you, Fiorina. Anything you'd like to add that I've forgotten?
Oh, that was amazing. Thanks, Jo. You've said it perfectly. I couldn't add anything to that. But what I wanted to just talk about was what other things that we're doing to support all of that communication work. And that is that we are working hard in the district to acknowledge or recognise communication as a significant factor for, you know, in patient safety. We see it, it's there all the time, but it's too often not seen as important until something actually goes wrong. And we want to change that and really get there and probably take a risk mitigation approach to see this as a clinical risk for patient safety. So we've done things like roll out a whole of organisation approach for Teach Back, our 3 steps implementation guide, where we're linking Teach Back to clinical risks. So points in the clinical communication where it's really critical that understanding happens. So getting teams to work on those critical points and use some data to help them understand and patient experience to help them understand where those points might be. In 2021, we also introduced a standardised approach for inpatient safety incidents. If communication is a main contributing factor for this particular incident, that will trigger a teach back recommendation, which was a huge win for us because it means that it's integrated, and we've done a lot of training off the back of that. So what Jo was just talking about with obstetrics and gynecology, that's how that happened. So there was an incident, it was investigated, communication was understood to be a main contributing factor, and that triggered a teach back recommendation. So look, we'll take it. If they're told they have to attend because of a patient safety recommendation, that's fine, as long as staff are coming. And as soon as they are there, even though they might have been a bit reluctant to come in the first place, they're really engaged in the training. And when we bring in a consumer, as we did with Jo, to talk about her story, and Jo's had significant interactions with the health system, they are even more engaged. And so it was great to have that kind of approach. So that's what we're doing with our teach back, but we still have a lot more to do, and we really want to see teach back, and Jo alluded to this as well, working hand in hand with shared decision making, and working directly with consumers and their patient and their family and carers to build awareness there and to encourage question asking and things like that. This is where Christy takes over for a couple of slides.
Thank you, Fiorina. So why is health literacy important to us in the renal or kidney service? Well, like Fiorina said, it's all about looking at risks. So when we're caring for someone in our service, it's someone with a complex chronic disease. And people with chronic kidney disease may not understand how to use health information to best support their decision about their treatment and management. So health literacy became a priority in the renal service so we can improve health outcomes and help them manage their disease to avoid complications. So what did our approach include for the renal service? So we implemented Teach Back. So we did, over a period of 3 months, we did 6 interactive workshops where we involved consumers in role play and feedback to the healthcare professionals. As awkward as everyone felt during the role play, that's what they enjoyed the most at the end of the day. That's where they gained their most learning, was the interaction with the consumer and having their feedback. We embed Teach Back into quality improvement projects. So we had recently did a quality improvement project, and rewriting resources and creating resources using Teach Back and plain English was actually one of the primary drivers to the project. We have health literacy ambassadors within our service, and we also have a renal consumer that we involve, is heavily involved in our quality improvement projects. So we've partnered with our consumer. Like I said, he's an integral member of the team for a quality improvement project. He reviews patient information that's uploaded to the patient information portal. Also participates in education as a consumer representative with chronic kidney disease in other consumer education, and also for our nursing staff. A direct quote from Nathan is that we are an army of angels, and he really wanted to give back to the service, and he enjoys being part of the organisational structure of the kidney service in order to meet the needs of our patients, community and workforce.
Thanks, Christy. I'm presenting these 2 slides on behalf of my colleagues, Natalie Berg and Kynwynn Johnston, who work as clinical policy managers. Following on from the success of our patient information portal and PIP process, we've been able to do a major revision of the way we develop our policy documents. So making them basically adopting a health literacy approach to our policy work. So they now have to be in plain language at a reading level 10 to 12 years. There is a governance system that supports that. So we have, as we have for our patient information portal and PIP process, we have policy documents that govern all of that work and how we do that and what staff and consumers' role in is in all that work. We have training programs now for staff. We've included this into health literacy ambassador training, and there's a resource portal. We use the same Hemingway tool which is the readability tool for both our consumer resources and our policy documents. And we have evaluation tools for staff and consumers. All of this has been largely modelled on the PIP process, but adapted for policies using evidence and best practice. There was a lot of significant challenges here. Many staff saw this as dumbing down documents, and that was probably the major challenge for us. We had to really work hard to push past that and to help staff understand that it wasn't dumbing down at all. Health literacy ambassadors played a big role in this within their own services and teams. Just, you know, even just being able to say to staff, you know, we're not writing these, you're not writing a document for yourself, you're writing it for others too, and you want them to understand it, and hopefully you want them to understand it the first time they read it. So saying things like that in a really conversational way, in a plain way, helped staff to understand what it is we were trying to achieve. And then in 2022, the Ministry of Health in New South Wales actually released a policy document that said that policy documents needed to be in plain language and so forth. So that was great to see that happening statewide. This slide shows a table from a study that was done in 21 and 22 with the University of Wollongong, where we wanted to see whether it was making a difference. With our health literacy work, we're constantly asking questions, asking ourselves, is this making a difference? Is this working? What are people telling us? What do they like? What don't they like? It's really important to monitor constantly and measure the impact. So we were able to see that through introducing this new system for plain language based on health literacy principles, that we were able to decrease the readability level, so make them easier to read. We were able to decrease the number of sentences that were really hard to read, decrease the length of the documents. I mean, this is early days. We're hoping to continue to improve. And we also were seeing that policies or poor understanding or application or use of policies had dropped as a major problem in our patient safety space between 2018 and 2022. So that was really heartening to see that things were tracking in the right direction. And Gail has been working in this space as well with our policy managers on a health literacy project. So I'm going to hand over to Gail.
For that, I've just got a quick chat with you about a really exciting project we're doing with the Clinical Governance Unit. And we're looking at developing a training module for consumers on health literacy and understanding plain language. I'm a member of the local consumer advisory group, and frequently we're asked to review health policies, documents, posters, flyers to see if it's easily understood and feed back up the information. And some might think this is a pretty easy ask. So in doing this developing of the training module, I got a group of consumers together and asked them what they understood about health literacy and plain language. Some really interesting answers. Some thought it was health books being published and we'd have to review them. Some thought it was government handing down directions to the health services that had to be reviewed. And of course, the very general thought about plain language was we were just dumbing it down. So in gathering this information really led us to urgently to start to develop a training module for consumers to help them understand health literacy and what they're looking for in plain language and why they're doing it. So together we've joined forces with consumers and the Clinical Governance Unit, and we've completed the training module. In the next week, we're rolling it out with a group of consumers. And in that group, we'll certainly have the people who thought that their lack of understanding. So following the training, we obviously will get their feedback, and we'll be looking for the impact of this training and their more thorough understanding of health literacy and plain language and what they're looking for. And once we get that feedback, we'll obviously make some changes to the module And from there, we'll roll it out to all existing consumers and then any new consumers. So the next time we talk, I hope we've got some really, more exciting news, because I think we've talked a lot about health literacy and plain language for the health side, but really when you're looking at consumers, and especially some consumers that aren't using the system a lot, they have very little understanding of health literacy and certainly plain language. So thanks.
Thanks, Gail. That is an exciting project, and it's long overdue. I think that's a really fair and accurate comment, that we tend to really look inward too much and focus on our staff and our own skills, which is important, but we need to be doing more work to balance out the equation and doing more work with consumers. But it's really, at the same time, it needs to be consumer-led. So we're really grateful for Gail's, passion and interest for this work, and that's happening next week. I didn't even know that, so that's fantastic that it was so soon. So how are we doing? I mentioned early on in this presentation that we developed our health literacy framework in 2013, and I think that was like the first one in among health districts in New South Wales. And there was a lot of interest in our work, and there still is, and that's so wonderful to see. But how are we doing? And this for us is a bit of a report card, and we wanted to be honest with you. Yes, there are things we are doing well and that are now embedded in the way we do business, if you like, but there are other things that we need to work a bit harder on. And I mentioned the 10 attributes for a health literate organisation that are still globally recognised as best practice for how to become a health literate organisation, bit of a blueprint. And we have been very successful in engaging our leadership, making this part of our operations and structure. We've been able to ensure that it's part of patient safety and quality improvement. We've got a great health literacy ambassador program that's growing all the time, that helps us to embed health literacy, implement the programs for health literacy and initiatives. We still need to do so much more to include consumers in the design, implementation, and evaluation of health information and services. But you've heard today from Gail and Joe about some of the work we're doing together in this space. And while in the past we've had various iterations of a consumer advisory group at the district level, we've been brave enough to acknowledge that they haven't worked very well, and that it hasn't met these structures haven't met the needs of consumers in the main. And so now we've got a completely different approach, and we're starting again, co-creating this, and we're really excited about what's ahead. And hopefully this will be a green box in our traffic light system not too far in the future. We have got more work to do in Teach Back and interpersonal communication. We're gaining traction all the time, but we need to work harder and make this as our work on how we develop plain language patient information resources, how we do that, how we do wayfinding. That's how we want to see Teach Back working, just everywhere, as part of normal communication between healthcare providers and patients and family and carers, but also linked to key risk areas and communication points. We're doing well with wayfinding, and it's absolutely embedded in our organisation, and it's as part of that, we involve consumers, and we always make sure to feed back to consumers so that consumers can come and see the changes we've made. It's important that we're accountable to our consumers, and respectful. So if we're going to involve consumers in anything, then we respect them by having them as part of the decision making, but also as part of the feedback. We need to do more around, again, Teach Back. We've talked about that, and we haven't really addressed the last one, which is plain language information around the costs that a patient might incur when they come into hospital. So we have got some more work to do. We're in it for the long haul. It does take time, And I think that if we do things in a staged way, which is how we've always approached our work in health literacy, then there is a greater chance that we can embed the improvements and the programs and systems we put in place for health literacy. So practical steps that we can share with you, our learning, if you like, and what we've learned along the way. I think having a health literacy group that is at an organisation-wide level, doing a bit of an organisational assessment to see where you're up to is a great way to start. Absolutely getting resources and support for health literacy. And you don't have to have a lot of money to do this. I mean, we had a zero budget. We still have a zero budget. It's just it's being managed by clinical governance at a whole of district approach, and that really helps. So we have a dedicated portfolio for health literacy within clinical governance. It's absolutely linked to quality and safety, and the principle of universal precaution underlies all the work we do. Having a system for plain language patient information that again is whole of organisation is critical. It's kind of like at the core of all your health literacy work, all our health literacy work, skilling the workforce and consumers, health literacy, a health literacy champion program for staff and consumers. We're just catching up with our consumer work here. We've got a long way to go there too. Wayfinding is critical and can be a great way to introduce staff to health literacy. Teach back and check back, as Joe was saying, the two have to go together. It's not just about teach back and training with staff, it's also about check back and education and awareness raising with consumers and for shared decision making. And always partnering with consumers in everything that we do, in all health literacy programs and initiatives. The lights just come back on. And monitor, record, and measure, get feedback. This is really important from staff and consumers. Always do that with your health literacy work because you're going to be on that journey for a long time, and you need to understand where things are working well, where they're getting made, where the big impacts are happening, and where experiences are changing for consumers and outcomes are improving. So thank you very much. There's some references there. Some of the things we've spoken about today are mentioned in our presentation. You can refer to here. And our papers that we've talked about, where we've been able to work with the University of Wollongong and the University of Sydney to measure the impact and effectiveness of our health literacy work. These are referenced here. And we'd like to thank a few people. Lucy Vella is my job share partner, and we've been on this journey together for the last 10 years. So without her, it would never have happened. I've mentioned Natalie and Carmen, who works with Christy in renal services, Associate Professor Kelly Lambert, who started in health and was one of the first health literacy ambassadors, is now a partner with us at University of Wollongong. Kylie is our Director of Clinical Governance. We have a couple of, Michelle and Claire, who have worked as patient information portal coordinators, done an amazing job. Thank you to our ambassadors. Thank you to our consumers and carer partners, and thank you to our staff. And thank you to the Commission, Anna and Rashin in particular, for giving us this opportunity. We really appreciate it.
Well, thank you so much for that presentation, and I'm sure everyone will agree it covered so many different areas, and there's so many valuable takeaways from that. So I'd like to introduce the team from Illawarra Shoalhaven Local Health District, and they're here to answer some of our questions today. But thank you to the team for that presentation. It was really good and lots for us to learn. I'm going to start with a question here. I'm interested right at the beginning, Fiorina, you mentioned that the journey started about 10 years ago. And is that how long you'd expect it to take an organisation starting today? And what were sort of the biggest challenges that you found on the way?
Thanks, Anna. No, we wouldn't expect another organisation to, it would take that long. We're really pleased to see that there's so much information out there to help and guide people in health literacy now, particularly for what works. And that is critical, knowing how we can translate health literacy principles and strategies into action. And I think there's so much more information out there. And since we started in 2012-13, we've got all the work from the Commission. We now have health literacy embedded in Standard 2, which has been a game changer. So that's really critical information, and there's work happening at a national level for a health literacy framework, and there's a health literacy framework in New South Wales. So all these great guiding documents and experience from other organisations, but we've also shared our resources with anyone who's asked, and particularly we've had lots of people ask us for resources to start their own patient information, plain language patient information system. So we've even been able to share like the skeleton of the website, the tools to test resources, etc. And one a local health district actually said to us that we'd saved them 3 years' work by sharing those resources. So I think as a community, by being able to share learning and evidence for what works is how we can save lots of time. So while it's taken us a long time to get to where we are, I don't think that would be the case for anyone starting on a journey now, no.
That's great. And obviously we can all just piggyback on the work you've already done there. I think that will save a few years. So I'm really interested in the PIP tool, I think, as are a lot of people listening in. And you mentioned step 3 involves consumer feedback through a consumer information feedback tool. That sounds really exciting. Can you explain how it works?
Sure, and I'll ask the other people here to maybe add some information here as well. So we have a governance system for plain language patient information. So we will require, all staff are required to follow certain steps and to produce, to co-create a resource. And one of those steps is to test the resource with a minimum of 5 consumers who will be using that resource, or maybe someone, for example, a carer, a family member who'll be supporting the patient or client to use that information. So the author of the resource will use the patient information feedback tool with patients or families and carers, and sometimes through an interpreter. That can be done through an interpreter, which works really well also. And we'll use that feedback together with staff feedback, because all the resources go on draft for comment, as would a policy document. They go up on draft for comment for 2 weeks for staff to provide their feedback. That feedback together is all logged, and then so staff are required to write down on a log sheet what feedback came in from who, what was said, and what they did with that, the action they took with that feedback. So that then results in a much improved resource with all that feedback. And doing the study with the University of Sydney in 2019 showed us that that is exactly what happens, that those resources do improve with feedback. But Christy, did you want to say anything, or Gail or Joe, about that process or being involved in it, or anything?
Yeah, so as a health literacy ambassador, I think before it even goes through the patient information portal, we encourage people to use the Hemingway tool to see at what grade the resource is reading at. And that tool is really good because you really immerse yourself in writing this resource, and you then put it through the readability calculator and realize it's actually reading at a grade 12, which is too high for as a consumer resource. So it really checks, you're able to check yourself and then rewrite the resource at a lower grade is really useful, I find.
And Gail, I think you're leading some work to develop an education model for consumers. Is that part of the patient information portal, or is that a separate project?
The separate project. I'm on a consumer advisory group, and frequently we're asked as to review policies or documents and give feedback through the PIP process. And as new consumers come onto those groups, we have found that some consumers don't really understand health literacy in plain language and how it relates to person-centred care. So we thought all new people coming in should have some training that helps them better understand that process and why they're doing it and the importance of it, Anna. So it's really exciting. And the consumers I've talked to are excited to do the training. So
excellent. And excuse my ignorance, but so for instance, if you have a document and you want to put it through the patient information portal, what's the sort of turnaround? Do you have 5 consumers that are there ready to review it, or does it take a while to contact people, check their availability, etc.?
I'll start with this. Look, I think that we would be lying if we said it didn't take longer. It does. But it's obviously going to result in a far superior resource and information for consumers. But yes, it does take. We encourage the authors of the resources to work with the consumers that are in their service, that are they're working with day in, day out, and their families and carers. And that way, it's just about having a conversation. We're putting together this information about, we'd love to get your feedback. Would you mind just at the end of a consult or an appointment, could you have a read? If it's a non-English speaking patient, then we can do that. We can ask the interpreter to stay a bit longer to do that. And interpreters are used to that, doing that in this district anyway. And so that really does, that's how it works. And sometimes we might send it out. And as Gail talked about, sometimes we might say, for example, it's a resource about healthcare rights that we've developed. So we might send that out to the consumers who are part of our consumer advisory groups in a hospital or in a facility or a service, and we'll get their feedback on that. So that's another way we can get feedback. So, in that individual patient care space, we encourage that wherever it's appropriate, but also that might be through advocacy groups, advisory groups where consumers are involved, depending on the resource really and who it's targeted at.
That's great. We've had a lot of questions about measurement, and I think as your presentation progressed, we could see how you had embedded measurement of particular tools. I'm just wondering about sort of consumer engagement as a whole, and how you measure consumer engagement and make it meaningful. That might be a good one to ask of the consumers. Jo, I don't know how you feel about how you make it actually meaningful.
I think measurement is used in so many areas as far as data is concerned, but I think you have to take into account the things that aren't measurable, and they are the things that where we can provide information, provide perspective that that perhaps isn't seen from the staff point of view, and you can't really put a number on that. And I guess the way we see it, a lot of us who contribute, we do it because it enables the next patient to have a better experience than we did, hopefully with our contribution by giving a broader perspective of what it's like to be in this process. And I guess it's always remembering that we are not something that so the service is done to. That's why we are working so hard to become partners in the whole process, to say that, and this is the perspective that we can offer. So yes, you can measure the number of interactions we have, the amount of documents we look at, the amount of committees we're on, all the quantifiable things. But from our perspective, I think it's the intangible that's just as important. Our opinions, our thoughts, the way we see things. These are critical to creating a better experience, better human experience for both staff and patients.
Great. And interesting to hear, how do you ensure that diverse backgrounds and experience are represented through the consumers you engage? might be aimed more at Fiorina, I think.
Yeah, that's you mentioned in the first question you asked about challenges, and I think this is a challenge because some people's voices, some people are going to struggle for their voices to be heard, and so our role from an organisational responsibility perspective is to have processes and ways we can make sure those voices are heard. So I've already mentioned how we very early on when we set up the patient information portal and the PIP process, we involved the interpreter service and we told them about what we were doing. We said, look, we're going to ask you to help us with this work. So they knew very early on that this was going to be something that might be, you know, added on to the end of a consult or an appointment where we might ask them to stay to get the patient's feedback on a consumer information resource. And so that's accepted as part of their role and part of their work. And that was an important step we took to integrate, to make sure that we could hear the voices of people for whom English might not be their first language, or they may be deaf. We are looking to increase the diversity of the people that we partner with in the governance and service planning space. And that is something that we need to do more work on, and to work much more closely with the community and the different communities really. And I think when we spoke about in the presentation about how we've been brave enough to say, well, our consumer advisory group at the district level wasn't working and we need to start again. It's one of the things that's on our agenda always, constantly, to make sure that we involve everyone, all the different communities and people that are out there, to make sure that we hear everyone's voice, and we make sure that we have people, the different communities in our Illawarra Shoalhaven district represented on that group. But it is a challenge, but it's something that we are very conscious of and we're working hard towards.
That's great. And Christy, you work as a nurse educator. Can you tell us how you incorporate your role as a health literacy ambassador into that work?
Yeah, so starting out as a health literacy ambassador, Fiorina encouraged me to look at communication as a risk in my service. So identifying the risks in my service, then I was able to implement some changes to support health literacy. So we actually embedded TeachBack into our everyday practice to make sure that the communication is safe, effective, and of high quality. So that's how we looked at health literacy, looking at our areas of health of communication risk.
Excellent. And can you just give us a little bit more information for those that don't know exactly what TeachBack or Checkback is? Can you explain it to us?
Yeah, so TeachBack really puts the onus on the healthcare provider to ensure that the information they're providing is understood. So this is using plain English, not using medical terminology or jargon. And it's really just having a conversation and saying things like, just so I know I was clear, can you please repeat back to me what I just spoke about? Or when you go home, what are you going to tell your wife? So those sorts of examples. It's a really fluid conversation. It's not saying, did you understand that? Nodding your head, looking for that reply back, saying yes. It's really putting the onus on you. And you find the more you do it, if you more comfortable you become with using that terminology. And we even recently used TeachBack in a video. We developed a video resource, and it's to be given at the bedside to consumers, and that incorporates TeachBack. So you can incorporate it at any level. You can use it at people at home, you can use it on your partner at home, you can use it at anywhere really.
That sounds like a plan.
Yeah.
Great. And a really interesting question here. Have you considered digital health literacy and whether you can incorporate that into the work that you're doing across the LHD?
So you're referring to information that's available on social media and other things?
Yeah, that and it probably in a way almost ties into Wayfinder and accessibility in terms of whether people can access
like apps and tools that people can use. This is something that we have considered and understood is important when we've put together our policy document for plain language consumer information, and we've made sure to include it there. We have done that, but not consistently, and we're working with media and comms constantly to make sure that we can do that better. But it is an area that we need to work harder on. When we recently made some improvements to our internet site, because of the work we've done with the patient information portal and how we work with media and comms in that space, they made a big effort to make sure that in all their consultations that plain language was a requirement for the content of information on the internet, on our internet pages. But in terms of the digital space, I think there's a lot more we could be doing there. But we are starting to, yes, and we have made significant inroads into some of that space.
Excellent. So I guess what probably including digital health, but what are the sort of the key challenges that you see ahead of you in the next 5, maybe 10 years?
Okay, that's a hard one. I'll say something. Maybe I'll throw back to the others on the panel to add what they'd like to see, what they see as the challenges. I think for us the challenges are always to ensure that health literacy programs and systems are embedded in daily practice, that staff and consumers see the benefit of health literacy approaches and health literacy programs, that we teach back and check back are going to be big challenges for us. We're started and we're confident of our approach and our partnership with consumers, but we want to make that, as it happens for Christy in the renal service, we want to make sure that happens in every service. So, and that the health literacy ambassadors are really key to making that happen. So we understand we need to do more work with our health literacy ambassadors. We're currently doing a study with the University of Wollongong to look at the effectiveness of our health literacy ambassador program, of the effectiveness of the implementation, and we're learning so much just through doing that. But these are going to be key challenges for us. And I think also growing the patient information portal and making it more outward facing so that consumers can access those resources through our internet. But critical to that is securing more resources for our work in health literacy. So these are what we see as our key challenges for the future. I might just throw over to Gail and Joe. Maybe start with Joe and Gail. What do you see as the key challenges moving forward?
As soon as I liaise with a concerned or about the moving into a more digital health care service, I suppose, they worry about workforce issues and how they will access healthcare. So I think they're relying more on the information side and how they'll access that. So I guess there's all the challenges there of how we do that. So because not everyone, many more people will access it through the digital process, but yeah, moving into that field, I think, has got its challenges to make sure we don't let any gaps fall, any people fall through those gaps too.
Joe, anything to add?
I think just developing a more true partnership model where we can be equal partners in our health and wellness. I think that's a key to keep continuing to work together to get the best possible outcome.
Great. Christy, anything from your side?
As Fiorina mentioned, the implementation of TeachBack is always a challenge. In my service, we did implement it. However, nursing staff have left, new people have come. So keeping up with that training of TeachBack is difficult and is a challenge. However, we do have the aim to continue it on. And as a health literacy ambassador, I get wind of someone developing a resource and I go, oh, let me have a look at that from a health literacy ambassador. If a new policy comes out, I put my eyes over it to make sure it's written in plain English for other healthcare providers. So having a health literacy ambassador within your service can really mitigate that risk surrounding communication.
That's great. Look, I'm afraid we've come to the end of our session, but we have many people wanting to access your tools and to get more information about specific details. So you put contact details on the end of your presentation, and we will publish that live in the next week or so people can come back and access the information there. Or if not, you can contact me directly and I can direct you to the right place. Look, I think somebody summed it up really well in the Q&A by just saying person-centeredness in action. And I think that really sums up what you've been doing across your local health district, and it's really impressive. So I'd like to thank the team for joining us today. We really appreciate the time that you've spent putting that information together and sharing it with us. And hopefully we can take some of those learnings and use them ourselves. But everyone, thank you for joining us today. If you haven't already, please sign up to our network. We have a newsletter coming out in the next few weeks with a lot more initiatives and innovations of people putting person-centered care into practice. And I'd like to thank you very much for joining us. Thank you. Bye.